A nombre de la Organización Panamericana de la Salud y del Departamento de Sistemas y
Good
Servicios de
morning,
Salud
everybody. On
y
behalf
la
of the
Unidad de Atención Primaria en Salud y Servicios Integrados, le damos la
Penthouse
bienvenida a este importante
Integrated
evento.
and Financial
Para nosotros
Services,
representa
we want to
un
welcome
punto
you
muy
to this
importante
important event. This
cómo
is a
presentar la
milestone
relación entre
on
atención
the
primaria de salud
presentation of the relationship
y el
between primary health
financiamiento.
care and
Tenemos
financing.
un excelente y
We have
distinguido
an
panel
outstanding
en
and
el cual
distinguished
tendremos como
panel,
principales
and
expositoras
the
a
main
Karen Hansen.
speakers will be
Ella
Karen
fue
Hansen. She
quien lideró el
led
reporte de la
the
Comisión Lancet. Es un
Lancet
enorme reconocimiento
Commission
y
on
agradecimiento a Cara y su equipo por
health
los aportes en
financing,
el análisis
our
desde las tres funciones de
recognition and
financiamiento
gratitude to
sobre las opciones
Karen and her team
para
for the
financiar
three
no
options
solamente la
on
atención
financing
primaria de
not
salud, sino
only
también
primary health care,
la
but also
integración tanto del
the
país, de los servicios,
integration of
como del cuidado.
services and care.
La gran pregunta que nos hacemos
The
es cómo
big
seguir
question we
en
ask
la
ourselves
visión
is
de las
how, at the
particularidades
region, we
que
can
esta tiene. Y
proceed,
uno de los puntos que
taking
quisimos
into
destacar
account
de
the
relieve
region's
en este
peculiarities. One of the
seminario
issues that we
es
wanted
la
to
importancia del
highlight in this
diálogo entre
seminar is
aquellos
the
que
importance of a
participan para el
dialogue
fortalecimiento de la
to
atención primaria de salud.
strengthen
En
primary
primer
health
lugar,
care.
el diálogo,
In
por
the first
supuesto, del
place,
sector
of
salud
course, a
con el sector
dialogue of
finanzas
the
para poder facilitar esa mayor
finance and health
integración de
sector so
atención primaria en salud,
that as
pero
to
también
facilitate
internamente
greater
entre
funding
los
in
equipos de
health
servicios
care, but
y los
also the
equipos de
integration between
financiamiento dentro de
service
los
and
países
financing
y
teams
también
within
desde el
the
nivel, desde el
respective
nivel
countries and
regional y
also
desde los
at
niveles
the
del
regional
país.
and
Entre aquellos quienes analizamos
country
las
levels among
recomendaciones
those
y
who
aquellos que se
analyze and
encuentran
provide recommendations
en
and
primera línea,
also those that are in the first
aplicando
line
y
of
operacionalizando
work
las políticas
charged with
hacia un
enforcing and
fortalecimiento de la atención
operationalizing these
primaria de
policies
salud.
to strengthen primary health
Un
care.
tema importante para
An
nosotros
important
es
issue
que la
for all of
discusión
us is
de la
that
integración
the
se
debate
encuentra más
on
avanzada en
integration
nuestra región.
is
Queremos ir más allá de lo que el reporte Lancet
also
muy
has
bien
made more
anuncia con su
steps
con
in
su
our
gran
regions,
aporte.
but we want to
No
go
debemos olvidar
beyond.
también
We
factores
must
como la
not
economía
forget
política,
factors
la
like the
gobernanza de los procesos,
economic
el rol
policies,
de
the
los recursos
process, the
humanos,
governance, and the role of
que está relacionada a la legislación laboral y el
resources,
diálogo
human
contigo
resources
probablemente
related
son los
to
principales
labor
motores
legislation and
del
the
éxito y
dialogue
predominante
with
del éxito
the
del
trade associations
enfoque de atención primaria de
and
salud
guilds
y de la
that
integración.
focus on primary health care
En este
and their
camino
integration.
tenemos también
Along this
a
path,
socios
we
claves, como por ejemplo los
are
bancos de
accompanied by
desarrollo y
key
los organismos
partners like
internacionales.
development banks,
En esta sesión
international
tendremos representantes
multilateral
tanto del
organizations, and
Banco
at this
Interamericano
session
del
we will
Desarrollo
be
como del Banco
listen.
Mundial y
We
también
will. This session will be attended by
sector
IDB, Inter-American
externo.
Development
Con
Bank
esta breve introducción
uh,
y tratando de ser lo más
members, and after this brief
digamos,
introduction, and in an
acuciosos
effort
y
to be as
lo más prolijos en el uso del tiempo, quisiera dar la
careful
palabra
in
a
our use of time,
Ernesto
I
Vasco,
would
que es
now like
nuestro
to uh,
jefe de unidad, muy brevemente,
turn it over to
para una
Ernesto
pequeña
Bascolo, who is
introducción
our
antes de
unit
dar la
lead
palabra a
for
nuestra
a
ponente.
brief introduction before
Bueno,
we turn it over to
muchísimas
Kara.
gracias, Claudia,
Yes, thank you very
y
much,
muchas gracias a todos
Claudia,
los
and
colegas que están
thanks also very
participando
much to all the
de este
colleagues
webinar. Para
that are
nosotros, el
attending this
webinar es
webinar. This
muy
webinar
importante. Lo
is
estábamos
very
hablando
important
bastante
for us. This
y
is
se
something that we
articula muy
had
bien con
expected
una serie de
to
webinars
have
que
for
nosotros
quite some
estamos
time, and this is
desarrollando
connected to a number of other
alrededor de la
webinars that
estrategia de
we're
atención primaria de la salud.
conducting
Es decir,
on
la
the
estrategia
health
de atención primaria de la salud no solo
primary
nos
care strategy.
organiza
This
en términos de la
primary
visión como
health
marcos, como
care
pilares,
strategy
sino también
organizes
la
our
necesidad
mission,
de
provides
discutir
pillars and a
cada una
framework
de las
for this
palancas
approach, but
de
also it
transformación que
allows
limitan, que
us
hacen
to
posible
debate
y
on the
hacen
various
efectivo un proceso de
transformational
colaboración
leverages
en la
that make
organización de
it
los servicios
possible
de
to
salud,
make effective
fundamentalmente
a
para garantizar
transformation in
condiciones de acceso en forma
health
equitativa a toda la
services
población,
industries in
con
particular
protección
to
financiera, y
assure
esto
the
es de alguna forma el motivo
appropriate
de este
access to
webinar.
these
Así que
services by the
muchas gracias,
entire private
Claudia,
population. And this is basically the reason behind this webinar. So thanks very much, Claudia, for those introductory words, and to all the participants and speakers that are have been participating in this sustainable effort over the last 3 years. And I also want to thank the participation of our department head, Mr. Fitzgerald, who would be sharing with us his closing remarks at the end of this event. So thank you very much, Karen.
Bueno, muchas gracias, Claudia. Solamente para saludar a todos.
I just wanted to very quickly greet everyone and join this webinar to promote a collaboration and disseminate knowledge. PAHO, after the COVID-19, a 3-year pandemic in the Americas, and that is still suffering from many of the consequences of this pandemic, feel that these efforts are key to recover lost services, strengthen health services, and make them more resilient to any future epidemic events. And from me, please accept my recognition to everybody, and in particular to the speakers that will be addressing this webinar today.
Please go ahead with your presentation, and thank you very much.
Okay, let me share my screen and check that I'm showing the right thing. Now, are you seeing the right view? Excellent, very good.
Yes,
okay.
yes.
Thank you so much for this opportunity to join you today for these really exciting discussions. I would just say that, you know, in the year that's passed since we first published the commission, there's been an enormous interest, and I think we were just really fortunate to be publishing the commission at a time when there's been so much emphasis on primary health care, partly as a result of the pandemic and the need, you know, the recognition of the need to sustain PHC. But I think, you know, more generally thinking about these issues of integration and transformation of health systems. And so that while I'm going to be focusing on financing, I think it's really useful to remember the two reasons why financing is important to PHC. One is that it helps to ensure that enough resources are available. It's about the mobilization of sufficient resources to support high quality primary health care. And the other is the ways in which financing arrangements, and that's what I will mostly be speaking about, can be used to support and in some cases to drive changes in the model of care. So I'd like you to just retain those things in the back of your mind as I go through the main findings of the report. So the challenge, I think, is one that's very familiar to everybody on this call, that general priority to health is limited, and that within health, that there's many pressures that favor hospitals. And what that means is that there is not enough money for PHC, that PHC resources don't reach the front line, they don't reach primary care providers, and that funding is fragmented and inflexible and inefficient. And so that leads to these three kind of key messages. One is that we need to allocate more to PHC. We need to allocate those resources equitably and make sure we protect them until the point when they reach the front line. And then we need to align the funding flows and incentives. And these all together will help us to spend more and spend better on primary health care. That's the main messages of our report. So what we set out to do in the commission was to present new evidence on the levels and patterns of global health expenditure on PHC, to analyze the key technical and political economy challenges faced in financing PHC, and then to identify good practice and actionable policies that would support low and middle income countries in raising and allocating and channeling resources in support of the delivery of effective, efficient, and equitable people-centered primary health care. So we started our work by giving a picture of what the landscape of PHC financing looks like. These are kind of almost like preliminaries before we got to the real work of the commission. The first is to understand that government spending on primary health care, particularly in low and lower middle income countries, is very low. And we start talking about numbers like $3 per capita in low income countries. That's an astonishingly low amount of financing. But even in lower middle income countries at $16 per capita, that's very, very far short of any of the price tags that we might place on primary health care packages, what it would cost to provide a minimum comprehensive package. The second is the continued importance of out-of-pocket payments. And so the green line here is out-of-pocket payments as a share of total spending. And even when we get to upper middle income countries, people are spending significant amounts of money on primary health care. So even in upper middle income countries, 45% of all PHC spending is out of pocket. And then another stylized fact is the fragmentation of this financing. So these figures show different compositions of financing by source at different income levels. But what we find broadly is that governments tend to spend money on outpatient care, that donors tend to spend money on prevention, and that households tend to spend money on medical goods, and by that we mean mostly medicines. And that picture is really pretty consistent until we get to high-income countries, where that changes quite a bit. Obviously, the external share disappears between upper middle and high-income countries. And this fragmentation, it's partly because of this interplay between low government spending and high out-of-pocket spending. So the less that governments spend, the more that individuals spend to make up that gap. It's to do with the high share of external spending at the lower levels of the income distribution, so in low and lower middle income countries. And then this kind of fragmentation in what people spend their money on. A third stylized fact is about the relationship between the level of government spending on PHC and service coverage. Because you might say, well, does it matter how much government spend on PHC? And this graph maps the UHC coverage index, the one that's used in the monitoring exercises against the SDGs, against government spending on PHC per capita. And there's a very clear relationship. It's an upward relationship. You get higher coverage with higher spending by governments. But I think almost as important here is the high variability in coverage for a given level of spending. So if you were to draw a vertical line, say at $5 per capita, or even at $50 per capita, you see that very different levels of coverage are achieved. And as soon as you see that variation, you think, some countries are doing a better job with their spending than others. And it asks important questions, not just about the amount that you spend, but that how it's spent, that can translate into quite different outcomes. And my final stylized fact is really about how providers are paid, and this is related to the incentives that providers face. And what you can see is that it's the kind of input. This is from a survey that we did of governments to ask how PHC providers are paid, and there is still a great predominance of provider payment for PHC through either input-based budgets, line item budgets, or through, when we say service-based budgets, we mean some form of fee-for-service, payment for output. And I will come later on to the significance of this for the incentives that providers face. So we organized our inquiry around the main health financing functions, but with some modifications. So we looked at revenue mobilization and pooling, which I'm not going to say very much about because I haven't got much time. We focused much more on resource allocation for PHC than the financing functions often do, because we felt that question of how do you allocate more to PHC was relatively ill understood, and the mechanisms for allocating more to PHC had not been fully explored. And then we looked at provider payment as a purchasing issue. But we also looked at the political economy context, thinking that these issues are not ones merely for technicians, that there's important political economy issues to do really with the prioritization of PHC over other areas of health spending. So I'm really not going to talk about the mobilization and the pooling. I want to zoom in right away to the resource allocation question. And it was the area that I found the most interesting, because it was the area of health financing that I was the least acquainted with, and kind of getting to terms with understanding the different policy levers that governments have to be able to allocate resources to PHC. But that was it was certainly the part of the work that I found the most novel. So we looked at kind of the public financial management functions, the budget formulation and the budget execution, and came up with a classification of the sorts of policy levers that governments have to try to prioritize PHC within government budgets. Things like program budgets or budget rules that require authorities, whether those are central or devolved authorities, to spend a certain share on PHC. Conditional grants as a way also of kind of tying money to PHC. I think in a way, one of the most novel things we came up with was this relationship between allocation and service delivery. And we found, looking at countries that were spending more on PHC, that they had a clear operational definition of what their PHC platform was. They often had some norms or standards that were used as a way of shaping the resource flow to primary healthcare. So some kind of choices about things like, where do you locate your lab services? Do you put those at the primary care level or at the hospital level? Those design questions were going to have a big impact on whether money made it to PHC. The role of the referral system and gatekeeping. But also we looked at countries that had developed new service delivery models, a new workforce for primary healthcare, for example, family doctors in Turkey or in Estonia, or community health workers in many other countries. And by changing that service configuration, that's a way of being able to draw resources to, it's almost like you're pulling resources to the primary healthcare level by having the right models of care. And I think this speaks very much to the work that has been done recently on primary care and thinking about models of care and the way that very close relationship between models of care and health financing. As a group of health financing experts, we were, of course, very interested in provider payment and incentives. And we argued that the way that primary healthcare providers are paid and the incentives that these payments create are an important tool to use to make sure that resources actually reach frontline providers and that they're used efficiently. And we argued that some form of population-based or capitation-based payment system creates the strongest incentives for providers to deliver people-centered primary healthcare. And that is for a number of reasons. One is that a capitation system starts from a principle of equality. It says we're going to start with an equal fixed payment per person. Then it allows you to adjust it for need, which is also a kind of an equity principle. We found that that paying a capitation type payment pays providers, it rewards providers for managing population health and for prioritizing health promotion, but also importantly that it provides a stable revenue base for providers. It allows them to steward their resources well and to make service delivery changes because they know how much income they're going to get on a regular basis. Now, all economists will tell you that there are drawbacks from capitation as well. Capitation can be associated with under-provision or with unnecessary referrals. And so we argued that while countries should start with a system that has capitation at its core, that actually a blended system that complements that or augments that with additional payment mechanisms to deal with certain types of challenges like high priority services where you might want to pay fee for service, or funding to encourage providers to reach coverage targets could be useful as well. And what do we mean by this blended payment with capitation at the core? This is a comparison. This is a look at the Estonian primary healthcare payment system and its blend. So you could see that in 2003 here on the left, when they introduced their capitation system, capitation was the main source of revenue, but not only. The providers received a basic allowance, and they also received some fee for service with some additional allowances. And then over time, that mix, that blend, was shifted a little bit to enable them to achieve certain types of public health priorities. And so by 15 years later, that capitation made up just over half of the total payment that PHC providers received. So how would we expect countries to get to this blend? It is through a gradual developmental process. So we sketched out what this pathway might look like, where you start with a status quo, whether that's paying either a fee for service or some form of input-based budgets, then shifting to simple capitation, over time developing the data systems that allow that to be adjusted, and then even further over time, augmenting that capitation with other forms of provider payment. Importantly, that change, that shift over time, needs to be underpinned by these strong health system functions. So thinking about information systems that generate data to be used to adjust payments, the capacity of purchasers, the autonomy and capacity of providers to manage those resources, and then the strength and the flexibility of public financial management systems to be able to handle more complex forms of provider payment. The last bit of our inquiry was about the political economy of financing primary health care. And here we started with the insight that technical solutions are great, but unless you understand the political and social economic conditions and opportunities, that the best technical designs in the world cannot succeed in shifting the bar in terms of PHC financing. And so by political economy, we refer to the power dynamics within stakeholder groups that are involved in the distribution and the redistribution of resources, but also the broader economic and social conditions. And these political economy factors they're often conceived as constraints or barriers to change. But in fact, they can also be opportunities. They could be an entry point for a political movement or for a stakeholder conversation about how to change the bar in terms of financing arrangements. And so this need for technical strategies to be politically informed and politically supported is really important to be able to understand and to navigate the political economy context as it evolves over time. So the core message of the Commission was this, that countries need to spend more and spend better on PHC. And then by better, we really meant think about what the attributes of a people-centered system for financing PHC is. So rather than just thinking about people-centered service delivery, we argued that the financing arrangements themselves ought to be people-centered. And what does that mean? So one is that the core of PHC funding should come from public sources. That's either taxes or social insurance, compulsory insurance. That pooled funds, taxation or insurance funds, should start by covering PHC, not leave PHC to last. And that those payments must include essential medicines because of the burden of the payment for medicines that falls on patients at the primary healthcare level. The third attribute is this resource allocation attribute, that that mechanisms need to be found to allocate resources equitably on this per capita basis, and also to use all of the levers of budget formulation and execution and service delivery design to make sure that these resources reach frontline providers. And that they should reach those providers through a payment system that has capitation at the core, but that eventually introduces a blend of payment systems. We also had a number of other recommendations which cover things like the need for a whole of government approach. And by that, we really meant both at the central level, the relationships between the Ministry of Health and the other agencies that are important for financing PHCs, the Ministry of Finance being an obvious one, but also the multiple sectors that are involved in delivering PHC. That technical strategies must be underpinned by this understanding of the social and economic and political conditions in a country and what makes change in PHC financing arrangements possible. And that there's also a need, and this is another issue which I won't speak about very much, though, to think about how PHC expenditure data are collected and classified and how they're reported to support national decision making. I think we have some very good global guidelines for measuring PHC, but those definitions that are used for measuring PHC at the global level are not always the ones that are the most useful in terms of creating direction and accountability at the national level. And that's an area of work that we hope to pursue in the next phases of the Commission. So allow me to conclude by just acknowledging our commissioners. So our commission met for 2 years throughout the pandemic. Our first meeting was in April 2020, and I know that entirely coincides with the very beginning of the pandemic. And so we worked remotely as a team with some fantastic experts drawn from the worlds of academia and policy and technical assistance. And then I'd like to just also acknowledge the Lancet Global Health Journal for publishing our work and the assistance that we received from the Bill and Melinda Gates Foundation. Thank you very much.
Thank you very much, Kara. You leave us breathless.
Perdón, estimada, que les corte. Eso quería hacerles recuerdo, que con las interpretaciones necesitamos hablar un poco más despacio para que haya una buena interpretación
Yes,
del
I'm sorry for the interruption, but because this is a webinar that is provided with simultaneous interpreting, so for the sake of a better interpretation, we need to speak a little bit more slowly. I wanted to thank Kara once again for the clear message that she has delivered, and I wanted to also mention that Kara is a professor and dean of the London School of Tropical Medicine and Hygiene in London. And now, without further ado and comment, I would like to turn it over to the members of the participants, to Ramiro Guerrero, who is a specialist, senior specialist in the health and protection at the Inter-American Development, and also to Gianluca Kefania, who is a health specialist at the Health, Nutrition, and Population in the World Bank's global practice. Jamiro and Rakula, we would kindly ask you for your reactions to the proposals that have been made by the Lancet Commission that Karen so clearly shared with us, and to ask you in the what other enabling factors you think are necessary so that the financing mechanisms that Karen mentioned, in addition to the political economy issues that she discussed, would allow them to accomplish their objectives of strengthening the primary healthcare strategies throughout the region, and how you, from your own viewpoint as members of the development banks, could support this strategy. Perhaps, Ramiro, you can go first.
Thank you very much, Claudia. I would like to greet all the participants, and I would like to thank you for the invitation and the possibility of commenting on this very excellent presentation, very thorough and very clear. Claudia was asking about the role the institutions, mainly the development banks, can have in this context, and I will start there. The banks work, our banks work because the governments ask us to do so, and we have to, respond to the context. And one of the issues would be a policy of persuasion, that is, to point out the importance of primary health care and the appropriate financing for this, and the concrete ways in this can be done. The banks, through their projects and their methodology, also provide a certain rigor in the results frameworks and the effectiveness of the results. But I would say that we should work together, that is the primary health care and the banks such as the IDB in primary health care by providing a common framework. And I believe that these conceptual frameworks, common frameworks, based on a common framework could lead to a more effective persuasion. One cannot be prescriptive, and we have to be clear about the means and the ends. And in each situation, there could be, in each context, there could be some appropriate means and others that are not so appropriate. In some countries, private participation would be meaningful, in others in which it would not be appropriate. And so it would be better to focus on the enabling factors, particularly slide number 15, where Kara was mentioning the enabling factor, the enabling factors, and one of these would be the moderation and these enabling factors for integration, so that there are, well, this is one of the first enabling factors. And here you can see with very much clarity and very much relevance the integration of care and of primary health care with other services. And there is a second set of enabling factors. For example, if it's of integrating primary health care with other factors. And I'm talking about interdependence. But this is a difficult issue. And then we have the institutional enabling factors. And here we have to deal with the resources. And in our task of establishing a dialogue in the different countries between the banks and the public healthcare sector, we can make progress in enabling the processing and talk about institutional reforms of a deeper reach in order to carry out our purposes. What we do and what we want is a system that is accountable, that is that renders its accounts, and this means that we need information about the results. Did the health status of the population improve or not? Was the personal expense reduced or not? If the results were not achieved, we have to have more data and draw our consequences about this. And so I liked very much your comments about capitation. Capitation is based on equality, and so financing follows the people, and this is the people-centered healthcare. It's the most important factor. Capitation is a manifestation of this, and there are some experiences, concrete experiences that we could share with some additional factors, such as correcting corrections that could enable a better capitation. So this is one of the conclusions about the appropriate financing of public health care. Thank you, Ramiro. Yes, the accountability is very important. We have to take it into account, and also the capitation mechanism that could improve this. Gianluca, please go ahead. Thank you very much, Claudia. Here, I'm Gianluca Campagna from the World Bank. I thank the World Bank and Mrs. Hansu for her very inspiring presentation. And so in my intervention, I will say a little bit about I will provide some comments about the presentation and to the World Bank perspective on this issue. Before starting, I would like to point out the importance of cooperation, interinstitutional cooperation, and about the possibility of being here in this webinar. This shows that the cooperation between institutions such as PAHO and the World Bank is a very important factor in order to improve the health level of the population. The primary health care and digital health are two very important factors here. I would like to stress two messages. I found it very good to stress the issue that it is important to invest more and better in PHC in the region. Clearly, the primary healthcare services are not being used enough, and they are not being used also as well for emergencies as they should be used in response and adaptation to emergencies. We have to use it more, and they are not only little used, but also little financed. We have to finance them more. So the second question would be how to do this, how to improve financing of primary health care. And here, about the enabling factors, I would like to point out that not everything can be solved with mechanisms for payment and incentives. That they are, of course, absolutely necessary, but they have to be coordinated and integrated. We're talking about integration with enabling factors that improve the impact of these payment mechanisms. So following the comments of Ramiro, I would say that there are different ways of looking at this. We can look at the enabling factors by dividing them into those that are related to investments and those that are related to governability and the regulatory framework. Regarding investments, one of the main issues would be the availability of data. And here, unfortunately, the information systems are not integrated in the region in the majority of countries. We still have to work on that. And this is not a very simple challenge, considering the present state of connectivity in the region. It's a very important region in the world, and most of the people in this region do not have access to connectivity, and so and the systems themselves are fragmented. the information systems themselves are fragmented, and this is a very important challenge for financing. So there are several concepts that are integrated and interconnected and that have to be dealt with in a comprehensive manner. Another issue that is important from my point of view is the management of change. In this case of the concept of care and the care levels. And this is about the patients and the professionals, and the payment mechanisms have to be designed in an effective manner, and the integration of these concepts are very important. And so this become important issues. And on the other hand, we also have a tool that has been very important for investment, and that's mapping the networks to see if there is a coverage throughout the network and understand in an informed manner where it would be important to enable. For example, there's a project from the World Bank of integrated healthcare networks in Peru, and we started to work on these networks based on a map of the network. And these are some of the examples regarding investment. Regarding the regulatory framework and the assignment of resources, which is the other category of enabling factors, there are some examples. For example, evidence suggests that if you have a strategic buyer that can implement payment mechanisms, so capitation also becomes an important factor, and also to enable the autonomy of the budget at levels that should be as close as possible to the primary health providers, so that they can be understood as administrative networks of for the budgets, and as well as the definition of a series of services or such as epidemiological services, for example. One example of a project that has being implemented considering many enabling factors is the SUMAR program in Argentina. That is an example of a financing based on success factors, based on enabling factors. And what the bank is doing is to support in the countries both not only investment programs, but also projects based on results where the disbursements are based on the results that are defined by the bank together with the countries. These are the two means in which the bank is supporting the countries. I would like to mention two examples. In Chile, for example, we're trying to update the per capita data and considering the epidemiological risk in the country, and another one in Costa Rica, where we finance the design and implementation of integrated networks for healthcare, taking into account during the design phase the enabling factors that were mentioned before. Thank you very much. Thank you, Gianluca. Excellent comments. Thank you for stressing the importance of investment and which are the specific areas in which this should focus, and also the regulatory framework And I also liked very much a comment about the management of change. And both Ramiro and Gianluca mentioned the importance of information systems and the role of digitalization in health as a very important factor that can help to uh, to overcome the structural barriers. I would like to leave the floor to Kara for her reactions, and I would also like to mention a factor that created a great impact and for us, and that was very important for us. So that's the assignation of resources before the financing, how this was shared. And well, we usually went to the mechanisms of payment directly, but the Lancet gave a very much importance to the assignation of resources and the mechanisms for strengthening the results. So, Kara, please, I would like to hear your comments on what was said by our panelists.
Thank you, Claudia. A number of really important and really interesting points that were made there. I think this issue, I'll start actually with the point about why we paid so much attention to the allocation of resources. One is because it happens very differently in very different systems. So, in some cases, and particularly in decentralized systems where you have budgets that are really managed, that are well outside the control of the central government, then any commitment to increasing primary healthcare spending is enormously difficult to engineer, right? How do you get your decentralized authorities to be able to be motivated to invest in PHC when sometimes their own incentives are more sharply political than at the central level, because PHC can be a little bit, sometimes it's a bit invisible. And so I think, part of our motivation was to understand just the enormous variety of ways in which you can influence the allocation of resources, some of which are just mechanistic, the use of budgets and the design of budgets in ways that make it possible to know what is being directed to certain service delivery platforms. But we were really thinking about where is there kind of innovation in resource allocation. So we looked at places where there are places like India, it's a large federal state where the center is very committed to increasing primary health care. How does it get the states to be aligned? And they do that through these conditional grants. So understanding the range of tools that are possible, because contexts are so different, countries are so different. In some cases they're highly centralized, in other they're very decentralized, and where you have decentralized authorities, you need many more policy levers to be able to direct policy from the center. I know that sounds a bit contradictory, right? Because decentralization is about being less directive, but sometimes it's important to align these the interests of decentralized authorities with centralized ones. One of the speakers talked about networks, and I think that's a very interesting area that we weren't able to find any good evidence on, but the idea of a model of care for PHC that involves networks of providers that allow the sharing of some key functions seems to be something that is happening in a number of countries. So understanding those networks, but more importantly, understanding how it is that they make their decisions about who will do what within a network. So which responsibilities will be taken centrally, which ones will be devolved, what is the most efficient way to organize this allocation of functions within networks feels very important. And then how can the financing arrangements support and reinforce that? So it's another area of evidence generation that I would love to see some more work on. And a number of speakers talked about the need for coordination and for integration. And in particular, thinking about provider payment. And that is absolutely central, right? We can't look at how to pay for primary health care independently of how we pay for hospital care. Because if you design your system without sight of what's going on at the hospital level, there's all kinds of problems that can be encountered, and again a drift of resources up the system. So if you have a capitation system for primary care and a fee-for-service system for hospital care, then you've got this toxic relationship between providers who want to refer up and hospitals who want as many patients as they can get. So that that really goes against the whole grain of trying to increase expenditure at the primary care level. So that integration and coordination feels like an important area as well, of exploring how it is that different countries have coordinated payment across these levels of care, and what are the lessons of good practice for that. So I'm sorry I couldn't possibly comment on everything because there was so much rich discussion there, but those are a few of the things that I thought were areas for further investigation as well. Thank you.
Thank you very much, Kara. Yo creo que tocaste los puntos principales y los más críticos.
Thank you, Kara. I believe that you well, you mentioned the most important issues in the region, the governability in decentralized systems, and for example, where primary healthcare is in charge of local levels. For example, the hospitals, but the hospitals are managed by the central government, and so the coordination here in the regional agenda and the building of primary healthcare networks are a very difficult issue, and also the integration of mechanisms to or financing that well, that become very critical. I would like to introduce Pablo Pagano, who will direct the discussion with about what Luca and Ramiro told us. Yes, it's true. This was not staged. At PAHO, our idea is to support the countries, and one of the challenges that we have identified is the financing issue and primary health care, and here the flow of financing to hospitals and to providers is very important, and it has to be adjusted to each country. We have a very well qualified panel here, and well, they are very well informed about different issues, and they will tell us about some specific challenges in their countries. We have with us Maria Soledad Martinez, who manages primary health care in Chile, Maria Angelica Borges dos Santos from Brazil, and Magdalena Rate from the Dominican Republic, who is a specialist in health financing and PhD in the Dominican Republic. Angelica will make her comment in Portuguese, and you can switch to well, you will also have the translation into English. We selected these case studies, and because they were countries that were very important for the Lancet report, and we're talking especially here about payment systems for financing primary healthcare in Chile, for example, and in order to find, and also in Brazil. So we here have specific questions. I will start with a Chilean case with Soledad. In the case of Chile, the local levels are the ones that are in charge of primary health care, and they receive resources from different origins. Soledad will tell us about this. It's not only the per capita, but other mechanisms that would lead to a certain fragmentation of the resources they receive. But from our perspective, the situation would be that the resources have a very well-defined recipient on the other side. So, well, the management decision about how to use the resources is a difficult issue, and how these payment mechanisms could evolve in the sense that the territories could be more flexible in their decision making, and what the issues could be here. Soledad, you have the floor. Good morning, everybody. Good morning, Pablo, everybody. Well, the truth is that I want to tell you, well, I want to tell you a little bit about the context of financing in Chile. We have capital funds based on indexes such as poverty and the age of the population, etc. There are certain things that we would like to improve and that we would like to be more precise in order to make the distribution of resources, but we are quite happy with capitation in general. We have a good evaluation here, and well, it's not only a financing through capitation. This is more or less the 80% is capitation of public expense, and the other percentage is about local financing. This is more or less the distribution of the financing, and these vertical programs, these are vertical programs that finance, for example, the available number of mammographies or the services for teenagers. So there is a space for the primary health care for teenagers in the different municipalities. So it's a distribution according to population, of course, but there are also some other issues here. The municipalities, for example, the municipal governments assign their own resources to PHC, and here this is well, the municipalities assign a very small percentage, and the great percentage of financing is from the government. And I was working with Cara and her help in the case of Chile before I was assigned to this position. So it was very interesting to have this information, because we also saw what progress we had made. We do not have payment for services, but we have these vertical programs that are based on a fixed budget that goes to the municipal governments to carry out these programs. We even have, well, we have about between 48 and 50 of these programs.
And this as a way of background, the question is whether this kind of a financing or funding is sufficiently flexible, and whether at a local level more can be done to make it more flexible when it comes to vertical programs. That's where I'm going to start. There is generally a certain flexibility and we finance a piece of equipment for a certain staffing, but the local level can introduce some changes to make it more relevant for their own local condition. That is concerns the vertical finances, but when it comes to per capita capitation, there is a significant amount of flexibility. And as Juan Pablo just said, a great portion of per capita in Chile is if goes to financing payrolls, basically human resources. So the principle, the idea here is not exactly because there is insufficient flexibility, but rather that there is underfunding of the family health plan that is capitated. So we have identified that there is try to increase that per capita amount base uh, per capita amount every year, but generally we conduct we understand that there is a certain amount of underfinancing, but in addition to the underfunding that we identify together with the London School in the document that we worked on together, there is another thing that is also quite interesting. There's something that I learned when I arrived at my present position, and that's the fact that in Chile, we have a health workers market that is highly unregulated. So what happens is that municipalities have a certain flexibility to improve the compensation, the salaries of health workers to lure them into their practices, and that creates a certain competition among municipalities. There are some municipalities that pay higher salaries for the same work than other compared to other municipalities, and of course that also creates the fact that a condition that there is an increasing amount of resources that are destined to payroll payments, and this may be one of the reasons why rather than insufficient flexibility in spending or the accountability of that payment creates this sort of disparity. Thank you very much. That's outstanding. It is very important to look at the details beyond the stylized facts that we often discuss, and also to document that how this relates to how a payment flow to other players like hospitals, for instance, that we're not talking about specifically in this seminar, but which Kara mentioned. But in the Chilean case, they seem to flow from two different sources. In the Brazilian case, we feel that there is a situation compared to Chile that is not quite opposite, but quite a different because municipalities and local governments are more involved in financing a primary health care in terms of their contribution, so that there is a greater capacity to make decision-making capacity at local levels when it comes to service provision, but that can result in huge inequalities in the availability and quality of the services that are provided. So we wanted to ask Angelica, who will be speaking in Portuguese, by the way, whether she agrees that there's greater independence, autonomy, and how these risks can be mitigated, that there might be huge inequalities among municipalities because of this independence.
First of all, thank you for inviting me. Thank you for your
Thank
opportune
you
question,
very
Juan
much, Juan
Pablo. And
Pablo,
it
for
really
your
has a lot
question.
to do with
And
what Kara told us in her
in the
last
I would
intervention. I would like
like very
to
much to
begin by
address the
uh,
final considerations that
explaining
were made by Kara, shared by Kara. I
PHC
would
in
like to
Brazil.
talk to
When you think
start
of
talking
PHC
about the
without
basic
drugs,
concepts of
medication, because
primary
that's
health care, and
another issue. Because
is this
out of pocket spending for
and in
medication
particularly in the
uh,
expense of
is around
medicines, which
80%. So we'll
accounts for
consider
about
that
80%, which
separately.
is a separate
If we think of
issue,
PHC in
different
the
dimension than
strict
PAHO's.
definition,
50 to
15 to
60% of
20% of resources in
resources
Brazil are
are
all
used for primary
allocated to
health care in
PHC.
Brazil,
Of
but
these
out of
resources,
these, 74% are
74%
public
are are
resources.
public funds. So this would be a very virtuous
type of behavior.
way of
In addition,
distribution.
the basic health units, that is at the
And
first level of
first
care,
level of
get
care
80%
institutions
of
receive
the
80% of our SUS
resources.
funds.
So
You are
you're
absolutely right, Juan
that
Pablo.
we
Our
have a
contribution to
composition
financing
where
model
municipalities
is
contribute
such
50%
that
of
municipalities
and the union, the
contribute
federation, another 40%
60%,
of the states,
the federal
10%.
level
But
contributes
you're
another
right, that is only a
40% and so
general
on.
average in
But you're
some
right. In
municipalities.
our 500,
In addition to
560
the, there are
municipalities,
500
federal funds
municipalities
are
for which
actually key
federal
because
resources are
most
critical for their
municipalities do not
health
have enough
activities because
funds
they do
to
not
make the mandatory contribution. So in my opinion, it's not the volume of funds that determines the power of decision. In Brazil, from the point of view of our framework for financing PHC, we have a very virtuous, let's say, mechanisms in place. Primary health care is strongly designed by the central Ministry of Health. Payment is made per capita and it's transferred directly to the municipalities. In time, we started in our 2011 program to increase quality. We started also considering quality of care. We also put in place other regimes of funding that considered also risks, and maybe they were not that well designed. But traditionally, this design of funding through capita and better results. To do so, we decided to create a program called Mais Médicos, which places doctors in places in localities in which there are not enough doctors. So in our fundamental framework, since 2006, all federal funds transfers are linked to what we call blocks. There are 5 major blocks. First, health vigilance, management, PHC, and others. PHC captured a large amount of these funds. These blocks made our municipalities, constrain them to use a certain amount of funds, a certain proportion in each one of these 5 blocks. From 2018, under pressure from local governments who were not able to use these funds as they should, there was a certain pressure to extinguish this concept of financing blocks. From that point on, financing was done based on other ways of spending. This gave a larger, improved autonomy to municipalities. In the design of the federal government as a whole, not the Ministry of Health, we found a larger preponderance of parliamentary measures in which the governments act as cells which apply these funds as they best understand. And health was one of the fields in which these parliamentary acts struck the hardest. This was one of the items that contributed to making this use of local funds locally more flexible. So now local managers can use these funds in such a way that is not directly directed by the system of blocks or any other measures or federal measures. In 2015, the federal union participated with 24 billion for PHC. In this same year, the municipality contributed 33, which we can see it was much above the participation of the union. Now, in 2018, we reached this moment of disruption. And in 2019, the union started participating with 36 billion municipalities with 37. That is, the change in our regulations directed municipalities to change, to channel their attentions to PHC. So the larger amount of participation of parliamentary amendments contributed to local flexibilization. And I normally say that what gave our central health system a national character, a national feature, gave us an overall way, a consistent way of directing resources. What happens now is that we have micro ecosystems that are absolutely different amongst themselves. There is a trend in local governments to withdraw financing from, let's say, hospital networks. So this faces us with an enormous challenge to respect local peculiarities, but maintain our global system outlook. We have several local systems that have a way of financing which is very transparent. We need more than that. Our systems do not communicate. We have one system that speaks about financing, another speak about systems or TI. What we need to do is to create meaningful interactions between these informational blocks. So our greatest challenge to maintain flexibility and effectivity and prioritizing PHC is in fact governance and availability of information to help us understand what is in fact happening in terms of quality of application for these funds that have been sent to local governments.
Un nivel de descentralización profundo en Brasil, mucha autonomía, el nivel.
I think that it's important to take into account that beyond the decentralization in Brazil, the central funding is still very important, and in providing nationwide incentives so that the local levels approach the national policy objectives. The Dominican Republic was not included in the Lancet Commission's studies, but to us, this is a country that is sort of a typical of the region. There are two public sectors. One is that is more contributive, and the other is social security related, and a public sector that is non-contributive and subsidized, where the services are provided, financed by general budgeting allocations. In the Dominican Republic, the primary health service from the public sector's non-contributive public services seems to be stronger, and there is a weakness in the contributive factors, and that is seems to be the situation in the Dominican Republic. So the question for Magdalena is whether she agrees with this statement that is supplied comes principally from the non-contributive public sector, and how the payment schemes and mechanisms and what policies could be designed for health financings to create policies that would contribute to homogenize a primary health service. In other words, against the segmentations, regardless of whether what regime you are under, so that everybody would have the same access to quality services or health services, that is same services. Over to Magdalena for her words. So, thanks for the invitation to this webinar. I would like to start by saying with what has just been said in the Dominican Republic, I'd say that the health service is an integrated service from various viewpoints, although from other points is disintegrated. So from a legal standpoint, there is a single health system and there is a single uh, health family insurance service that was set up in 2001 after the health reform that was perhaps very much ahead of its time. This was a health reform that was supported by regulated competition with a function, governance, provision, and insurance separated schemes, separate schemes. So that led to a model where financing was centralized through a social security treasury that gets contributions from the payroll formal segment of the economy, together with the government contributions that are transferred to the insurance companies that are private and public risk managers, and that are automatically transferred every month based on the number of affiliated populations. In addition, this system defines a service package that is designed centrally by the National Social Security Council. That's a collegiate body that approves the services that will be adopted and which are similar for everybody, whether in the subsidized and the contributive regimes. There is no difference between the two. So the difference is in the capitation, in the per capita. The per capitas are different from the subsidized and the contributive regimes because there is a transition period that has been postponed for several years because, in theory, all financing should flow from the supply side to the demand side. And that was the idea behind the system. However, a large most of financing, in particular for hospitals, uh, continues to be supply side driven. And so, if on the in regards of provision, the system is a fragment, but on the side of financing, it is unified. The capital is distributed homogeneously, and the decisions are made at the central level, and the package is decided also at the central level. It's decided by the central government. So there are quality differences, disparities, because in the contributive regime, absolutely the entire population resorts to private suppliers. That's about half of the population. And the subsidized regime scheme, both are used. Originally, it was basically the public services that were used by the government over time has uh, been unable to finance public infrastructure and human resources. So the quality has diminished, and the subsidized assure that's SENASA has to finance its public or private providers. And if they are not enabled, authorized, they are not paid for the services. So oftentimes they send their own subsidized regime patients to the private providers. So the Dominican Health Service is gradually becoming privatized because of the lack of sufficient public investment in for public providers, because the government has left them to their own sort. So when it comes to primary health, which is enshrined in Dominican legislation, in the Social Security law, in the health services, in the National Development Strategy. It is enshrined in all these components. However, it is not fully implemented finally, neither in the public nor the private sectors. It is not true that it is actually implemented only, not implemented only in the public sector, but in neither of the two. I think, however, there is a hope. For the first time, I have a greater hope that this will be a habit, because we now have in place a public sector health plan that has included the health issue in several of its pillars. This bill is just been published, and this is several of its pillars include, enshrine, and provides funding for this public health, and also in regards of remodeling and rebuilding public infrastructure, public facilities. But also since 2018, we have in place a list of Social Security services that has prepared, that is designed and funded to provide a primary health service both from the public and the private sectors, that is been funded without entry payments, including the cost of medications, medicines, and laboratory analysis, basic images, and all these basic health services. And this is budgeted for both the private sectors, and all stakeholders, players in both sectors have agreed to put in place this system. And SENASA has actually started to uh, enter into contracts with these networks, private networks. About 20% of the subsidized regime are under this system on a per capita basis, although this is not exactly the model that has been approved by the by the health ministry, health department. The our foundation is presently studying the barriers to joining these systems, and we have asked the stakeholders, and there does not seem to be any opposition to this plan. Everybody seems to agree that that strategy should gain a further momentum. I think there is a good expectations in that respect. We have also just finished the study on the national response that actually set an example for the entire region in regards to the response to the COVID pandemic. And this is a publication that of the Grace Foundation's Gates Foundation, examples of a global health, and that lists countries that provided a better response despite the inequities in the primary health care, because the country provided a good example in terms of leadership and governance. I think that perhaps finally we are on the right track. Thank you. Thank you very much, Madalena, and I'm going to retain a number of issues from your presentations, in particular the policies that are supply and the demand side. And Claudia is telling me that we're running out of time, so to close the panels and divisions, I think that what matters is to understand the specific context of each country. There's no one size fits all, and only a look at the stylized effects, but also the specific challenges that are faced by each country and to address them. And I would now turn on to Claudia to moderate the last part of our webinar. Thanks very much for all the members of the panel for their inputs. Thank you very much, Juan Pablo, for your moderation, for the outstanding panelists for sharing their country experiences. And before be moved to the last session, I would like to thank the participants who have total about 700 participants in this final segment of the panel. We're going to be listening to the institutional proposal from the World and Pan American Health Organizations. Of course, more globally from the standpoint of the World Health Organizations, but and a more regional approach from the Pan American Health Organizations. We have together with us Terry Reynolds. She is the unit head, lead for. Lo voy a decir en inglés.
Clinical Service Unit. Y tenemos también a Ernesto.
And we also have together with us Ernesto Bascolo, who is unit lead for primary health and integrated services. And so let me turn it over now to Terry to begin with. Terry, over to you, please.
Thanks very much, Claudia. And it has been such a pleasure to be here with you guys today and listen to these conversations and the excellent presenters. I am going to share a few slides with you. So hopefully you should now be able to see my slide deck, and we'll go into presentation mode in just a moment. So I have learned the hard way that presenting after some of these people, and I've done this before, particularly Kara, is always a challenge because there's two things. She's usually said what needs to be said, but also has said things in a very clear way that opens the door to more conversation. So I really appreciate that. I will do my best to summarize. I'm not a health economist. I am a clinician and I work, I have this unit called Clinical Services and Systems. So that is my anchor perspective. I'll do my best to summarize a few of the ideas that have come up today and to link them to WHO approaches and really try to connect the dots on the foundational concepts. Really, it seems there are four questions that we all have. One is what we mean by integration, which is a big question. One thing that helps with that is to say, well, what do we hope to achieve by integration? And then what do we need to do to integrate? And then the purpose of us coming together today is really to look at how might financing policy choices actually affect integration. So just to say, why is this difficult? Why do we need this many experts on a call to talk about it? It's because it's really an impossible task. There is no definition of integration that will serve everyone's needs. This was an excellent literature review. There were 175 overlapping definitions and concepts. They go on to say that that is partly because there's no less than 10 different health-related disciplines who promote a certain definition of integration. And therefore, and this is a nice statement, it's associated with a lot of different objectives. And I found this very helpful because it means that in order to have a coherent conversation, we need to identify what are the objectives that we mean when we say integration. Because I've seen many conversations happen where people are using very different definitions of the same word, and they are not understanding each other.
Excuse me,
but
Terry.
they think they are. Yes.
Excuse me, Terry, to interrupt you. We don't hear you very well. So maybe if you close your...
Sure, I'm on
maybe the audio is
headphones. Yeah, I'm on headphones. I'm not sure how to make that better, but let me see if I come off headphones.
Maybe if you close your camera, maybe we can hear you better.
Sure. Is that better at all?
I guess so. Yeah. Go ahead, please. Thank you.
Okay, great. I apologize for that. So when we talk about the objectives, why do we want to use financing to influence integration? What we actually mean by that is these 5 C's. I still find them very helpful. We want care to be person-centered, meaning that it addresses the person's needs, the person, including their context and their comprehensive health needs. We want them to to be able to access healthcare close to home. We want their first contact healthcare to do a lot of the job for them. We want their healthcare to be comprehensive, meaning that they don't have to go to a different place for every problem. We want this care to be coordinated, though, in the cases where they do need to access different parts of the health system. And finally, we want some sort of continuity, both across levels of care and also across the life course. And when we say we want these things, we are also talking about avoiding certain things. So these are the core things that come out. We want to avoid fragmentation and siloed care. We also want to avoid interrupted care and fundamentally poor quality care. And part of that is because these result in bad outcomes for people and lack of satisfaction for people. But it's also because each of these contributes to waste and inefficiency, and that includes information loss, waste of information. So another way of looking at that, and people have brought up different elements of this, and health economists like CUBE, so you will recognize the background CUBE. But here's a way to look at integration. We want, let's go backwards. We want integration across levels. And what that means is we want the community and clinic levels of primary care to be well connected to, say, the first level hospital, the second level hospital, and also to the transportation, communication, and supportive supervision mechanisms that connect those. We also want integration across conditions. So, gosh, imagine if you happen to have hypertension and malaria, and you might even have those things and get pregnant. We would like the idea of the comprehensive person-centeredness to actually be able to integrate people's care across conditions for a number of reasons, for the person's experience, but also because these different conditions influence and modify each other. And then finally, we want integration across the life course. We want people's care to be, we want people's health to be supported, regardless of whether they happen to have an acute problem or whether they are younger or older or pregnant. What that means in the end is something important, and Carol referred to this a bit, as have others, but really it means that primary care is present every day for everyone. However, almost every lifetime will be punctuated by the need for other levels of care, for the occasional ambulance, for the occasional hospital stay, et cetera, et cetera. And this changes, of course, across the life course. So really, we need to see if we can accept two shared premises. One, that more or less what we mean by this, that we want to get the right care in the right place at the right time. And by the right care, I don't mean that there's any one right care. It's a very person-centered idea. That is the care that is right for this person. So we want to say the right care at the right place at the right time. Then the other assumption that we seem to be making here is that financing policy choices can enable or disable integration. So we need to think about both of these. Financing policy choices can do a lot of good, but they can also do harm from that same power. So these are just with thanks to my colleagues, Matt Jallett and Susan Sparks at headquarters in health financing. These are a few examples that many of you know well. Earmarked external funding can fragment services. If you have multiple coverage schemes, they may end up executed as a series of mini systems. Budgeting mechanisms, if they're input-based budgeting, they may not be performance responsive, or they may not be able to dynamically adapt to health needs. Programmatic, narrow planning may not align with integrated primary care. Different purchasing payment systems can create conflicting incentives. And finally, they may be misaligned to the positioning of primary care as an entry point. And benefit entitlements in particular are very powerful in this way. They drive conditions of access that may not align with people's needs, but also may not align with clinical protocols and the right care for that condition. And concrete examples of those, for example, include things where people are required to present at a different hospital, even with a serious acute injury, where they would be better served by going to a designated center for their condition. So what do we do then? Within the WHO framework on integrated people-centered services, there are 5 strategies. I'm going to focus on the one that has been foregrounded by several of the earlier speakers, which is models of care. Models of care is a word that is almost as dangerous as the word integration. It has more than 175 definitions. out in the literature because we've done a review recently. But more or less what we mean here by model of care is what services are delivered, where and how are they delivered, and by whom. So in particular, if you look at the WHO PHC operational framework, you'll see the domains of models of care include UHC packages, defining conditions of access and empanelment processes, pathways that include referral and counter-referral, and then specifying the roles and functions of platforms. Now, every one of these has been mentioned in association with a financing policy choice today, whether that is packages, which are a financing policy choice in themselves, but designating UHC as your goal, benefits and conditional payments that define conditions of access, and networks of different kinds, service provider networks, or a broader use of networks that's coming into currency in some regions. And then specifically the roles and functions of platforms, which in some way are determined by budgeting mechanisms. So I want to flag one more caution, and then I'll show you some practical examples of what we mean by this. Integration is a coherent, this is put forth in a really excellent report from several years ago by the European Regional Office at WHO. It's a coherent set of methods and models across many levels designed to create connectivity. And that's fine, that is very consistent with everything we said so far, but they, in the conclusion of this report, made a very interesting point, which is that organizational and functional integration, so integration at these higher levels, did not guarantee, nor was it sufficient to achieve clinical integration. So integration at the point of care. And that's a very important thing to keep in mind. Now, these are examples that are familiar to many of you. I'll put them up just very carefully, just to say this is an old example when DRG-based hospital payment was being discussed in many ways. And the idea of you can integrate and do something that seems like the right thing at the financing level, and yet have a lot of unintended consequences. So when you try to reduce cost per patient, reducing length of stay may optimize care pathways and get people getting more care at primary care, but it can also result in early discharge of people who need to be in the hospital, et cetera, et cetera. The same thing for incentives to reduce the intensity of services. Coding practices. It can either make your documentation match your reality better, or it can cause people to tell a fairy tale, a false story in the documentation. When you try to increase the number of patients, decrease the number of patients, you can reduce waiting lists, but you can also end up with patients admitted for unnecessary services at the hospital and shifted away from primary care. So these are familiar pitfalls. I want to talk for just a minute about hospitals because one of the things we learned with a PHC approach, which from the WHO point of view is a comprehensive policy approach that is much broader than primary care, which is the delivery platform that we want at the center of PHC. So one of the things that we have learned is that if you want to put primary care at the center, you cannot do it by acting only on primary care. So in order to get primary care at the center, you must act on the things that are interfering with that. And that includes powerfully hospitals. So I know we're talking about financing mechanisms here, but as several of the speakers have foregrounded, hospitals in themselves are almost a financing mechanism because of the way that they have traditionally been financed, because of the role that they play in health systems. So a better way of thinking about hospitals to achieve effective primary care is to think of them as a concentration of scarce resources. We as a human species have decided, and this has consistently been the case, we need a place that is open 24 hours a day that can meet rare needs, that can respond to mass emergencies, that can do certain things, but they are a concentration of scarce resources and should not be at the center of the hospital. They can be deployed to be seen as resource hubs and to support the rest of the health system. So we need to rethink hospitals as a way of achieving our goals for other care settings. And I won't spend a lot of time on this, but we'll circulate with the slides, but hospitals directly deliver some things within their walls, but they can also facilitate in many, many ways what we want delivered at primary care and how we want it. Hospitals, again, should just be thought of as a concentration of scarce resources. Therefore, they are effective at delivering care, but they are very effective at supporting, supervising, training, so et cetera, et cetera. So we need to use hospitals as a mechanism. I'm going to quickly show you some slides because the other thing is UHC packages.
Terry,
Packages of services
we
for
have
yes.
2 more minutes at the
Fine,
most.
I'll go through
Thank
this very quickly. So I was going to say simply that UHC packages, whatever you think of them, even if you think of them as a finance mechanism, they end up being used for all of these things. And we know this empirically from countries. So these are the kinds of services that are often included in packages, but this is not people-centered. This is not how people come for care. So we have to be very careful with our packages because they have enormous influence on what happens with our service delivery. People come and say things like this. And what that means from the point of view of packages is that there's 2 things. They need to include the core functions that represent the continuity and coordination that we want from primary care. These services must be explicitly included in packages. Second, the services that cover the interval between when a person comes with a problem and the moment when we know what WHO department they belong to, that interval of a person-centered issue has to be covered also by these. And then finally, and kind of flag this, we really need, when we say treat injury, we need to know what we mean by treat injury. Otherwise, we will not fund it, finance it well, etc. We need to know what are the associated health workers, what are the associated medications, what are the associated tasks. And these are all examples of elements within our, it's a UHC package tool from WHO, but there are, of course, other sources for this. But this is just to communicate what need to be some of the characteristics of our packages. And finally, they need to pay attention to these other elements of models of care. They need these specific services to be defined and designated in a complementary way across the system, from the community, the primary health unit. As the example that was mentioned earlier, you want early recognition in primary care, but then you say recognize danger signs and refer, but you have no referral services such as diagnostics to support that, then you're not going to achieve the goals you want. And I'll just leave you with this last slide, which is this is from a group called National Voices, which is a patient organization. And this is the touch point that is used in England, interestingly, to define integration and make sure that they are constantly achieving their goals of integrated care with their financing choices. Thanks very much.
Thank you very much, Terry. Muchísimas gracias por darnos una visión tan amplia en tratar de definir.
Thank you for giving us such a broad vision to define the integration, both the services and the care. That's not easy. And also try to build bridges through the dialogue with the language of services and the language of financing. And without further ado, and regarding the time, I will now give the floor to Ernesto. Thank you, Claudia. Can you hear me? Yes, perfectly. Thank you. First of all, it's an excellent webinar or seminar or whatever you want to call it. From the presentation of Cara, the discussion of the organizations and the possibilities of financing and development. And this last presentation, was very timely, a very timely stress on the intention of service. Why should we provide these services? And I will try to sum up some of the contributions. First of all, of course, this has been stressed by the great majority of our presenters, of our speakers. Financing should be thought of as part of the functions of a health system and not as a parallel instrument, a parallel tool. And this, what you told us, was based not only on economic policy, but and also not only the assignment of resources to purchase, but also the performance of health services. And then we had to you helped us to understand why, what for. This premise that Kara was explaining with such clarity, which is to improve and increase the financing and public financing, and to improve its quality also, to think apart from the need of increasing financing, to think about how to articulate it with services and how this is focused on certain goals, on concrete goals. And well, in financing, we also have to talk about the expenses from the user's pocket and the financial protection. And using the framework of the WHO, in which we have participated and that we find very useful. In this framework, we are stressing equality and efficiency, the issues of quality and also the access conditions. This is the reason for being of public finance. Public finance focused on PHC and also the access to it. From our organization, we set up this framework for primary health care, where we not only stressed the PAHO focus on the pillars. Well, I cannot explain this in detail, but I am very grateful for Terry's presentation. And one of the issues is about integrated services and the essential function of public health. And this point of view also needs to incorporate the population and intersectoral policies and focus the point of view on primary health care on the needs of the population in a certain territory. But apart from the results where we incorporate access as a central issue, and many of you must have seen also the previous webinars, not only this year, but during the last years, we're showing here the usefulness of analyzing access problems as some way of articulating the needs, the health needs of the population and the response capacity of the systems. So I thank Terry for stressing this aspect as the main guiding point, because we need here well, strategic levers, and many of these were developed during today's seminar, not only as strategic levers, which talks about generation and assignation of resources, assignment of resources, but also the systems of purchasing and payment in order to strengthen these assignment systems. And when we concentrate our point of view on the Americas, and then mainly Latin America and the Caribbean, but the whole region also, something that we have is a very impressive segmentation system. There are different healthcare systems that are structured according to different financing sources, and they are based on the a logical focus, combining the social security systems together with public healthcare systems that are based on taxation, and on public and on integrated services of public health. And here we're talking about the public budget. The infrastructure, which is a characteristic of our systems, we have some emblematic cases. For example, in the case of Costa Rica, Social Security offers mechanisms not only that prevent segmentation, but also helping or supporting solidarity, even using different sources. In the case of Brazil and other countries, such as Caribbean countries, and also Canada and Cuba, where the logics behind the national services, health services, very important. And there is this intermediate space of a whole cloud of countries where there are segmentation problems that in some way explains the fragmentation of the mechanisms, assignment mechanisms. And Magdalena even has pointed out that there were certain risks and challenges in terms of solidarity and equality, fairness in the assignment of resources. And when we ask ourselves if we have the necessary resources, we oftentimes need to combine the fiscal sources and taxes and fiscal resources and taxes. And in general terms, there is also a hypothesis that if the priority in health is related to fiscal capacities, and if there are more public resources available on behalf of the state, this condition facilitates prioritizing health. This is the logic behind it, but we see that it's not like that, because we see that the expenditure in health depends on the respective government. And the component of political economy is not only important in assigning resources, but also in designing tools and means of payment, and to go from budgetary historical budgetary systems to capitation, and also the incentive for professionals and suppliers, and putting it together with the needs of the population. I also want to say that it makes much sense when we analyze this, when we look at public financing, that we could be considering as an average in the region. The good news is that there is an increase, quite a considerable increase in public finances. It's still, well, it's above 4.5 now, up a whole percentage point, but it's not enough, because it should be 6% of the GDP, but it has to be, we have to consider levels of development and GDP of the countries. But there is an increase. When we look at this decades behind in the past century, it's not easy to find 2 decades where we have achieved a growth of more than 33% of the public financing. And this is something I want to stress. And this also contributes towards reducing the personal expense of their own pockets. And this is so explained by the evolution of public expenditure and pocket expense, together with the variable of the GDP and the per capita income. We see that there is a certain relationship where the increase in public expenditure reduces uses personal expenditure. And this is the traditional analysis we make, but due to methodology also, when we consider different sources, the own support from of the users. Well, here it's more important to interpret two things that have been talked about in this webinar. First of all, the political decision to prioritize PHC. We have seen in a regional analysis that although we incorporated in the last 3 years the COVID services, well, we saw that there was an increase in participation of prioritizing public primary health care. But and here we see that if we include COVID expenditure, we see that PHC has not grown. It has even been reduced because of the COVID services. And this is linked to one of the other big issues that was developed during this webinar, and that has to do with making the systems, the resource assignment systems more efficient and more equitable. And well, we should look at this as several of the speakers say, not only as a process of governability structures in different countries, but also talking about the possibility of interpreting which are the critical capacities to go through this change. Obviously, when we incorporate the information systems as a necessary resource, that requires also the development of capacities and also for analyzing the needs of the population in a epidemiological sense, and their behavior also. And the other element that was commented upon, I believe that I agree that we have to expand the analysis of the network. We have to base our resources on the network of healthcare providers. And the financing mechanisms should enable the reinforcement of this network or even go beyond mere financing. There is also the development of networks in our region in several contexts, not only independently from financing contexts. And we have to prioritize our analysis of resource assignment and to improve these networks. I wanted to mention also that when we talk about capacities, there is also this issue that aside from the budget issues, we also have challenges of decentralization. And these flows, the analysis of these flows are also very important and for the change processes. And then we have the access barriers. These are not homogeneous among the countries and among the population of each country within the territory. This is our reason for being. It's our first indicator and result and dimension, immediate result that we have to consider when we apply the development of capacities and the development of our financing instruments. There are countries that, as a result of policies, have reduced the pocket expenses and they have resolved the access barriers, but other countries do have access barriers, and these are the main challenge. I do not want to go beyond this.
Thank you very much, Ernesto. Thanks also to Terry and all the other participants, in particular to Kara. And I now want to turn it over to James. And of course, thanks also to the members of the panelists for the country panels and to Gianluca and Ramiro for their important contribution. How can we materialize this integrated response? And how can financing contribute? Thank you very much. Yeah, that's a very important. In the first place, I want to congratulate Kara Ramiro, Gianluca, and Zola Marin Helican and Terry because for their outstanding contribution to this debate that uh, demonstrates the complexity of this issue, but also the wealth of knowledge as Claudia managed to move forward. And truly, we have a very strong evidence foundation that we have all been sharing today. And of course, as was correctly said, be used in a different health system context because obviously they are very different. But obviously, evidence has been put on the table about the importance of increasing financing for public health care, primary health care, with a strong emphasis on providing services to the people who live in those areas and to reduce the fragmentation and tackle the fragmentation in the health services. Um, this is, as I said at the beginning of this webinar, is the way in which we address this issue should be with a very clear vision about to improve access and coverage, but also with attention to quality and equity. And this financing has to be very much focused on accomplishing these main goals. This is our vision, and this is the vision that we have to push forward in public policy making in relation to the transformation of health services across the Americas. If we want to have a better and a more sustained health services, and also more generally social protection systems that are more resilient to any future pandemics, we have to move forward and making the necessary investments in public health care and reducing out-of-pocket expenses. And invention in these two things, the and financial protection for the to assure the health of the population in the Americas. And the last thing is about advocacy. I think that CARE was a very clear in their presentation. When it comes to the context of a political economy, this is something that has to be reviewed in more depth for each national context, looking at the players, social policies, and the demand and supply sides, and also focusing on the actors who have who play a critical role in decision making, as Terry said, to improve integration into financing and the integration of the entire package of health services. Policymakers are lawmakers are critical in this process, and we encourage them to continue in this national dialogue so that we can turn such a rich wealth of information and detailed knowledge that we already have into materializing it. So the road to the future is to continue moving forward and strengthening health systems for primary healthcare. This is financing is critical in this debate to improve quality and more integration. And having said that, I want to thank my team at the health services team, Claudia, Ernesto, Juan Pablo, Maria Claudia, and the entire team that has been involved. It is what we have accomplished is impressive. We have had almost like 750 people at attendees at this webinar, and this reflects the importance and the priority that the Americas are giving to this topic. We keep moving forward and in sharing at these webinars and other debates the knowledge in these issues. Thanks to everybody, and have a great evening. Thank you very much, and everybody have a great weekend. Thank you.